continue with your second talk and also compensate for the time that
For the time that this is really short, this other one is much shorter.
I will
Thank
also
you.
request the co-instructors to please come on to the chairs here.
Okay, so this is the other talk on the role of the lens in angle closure, differences from phacomorphic. So angle closure mechanism is based on variations in the anatomical or positional abnormalities of the anterior segment or forces in the posterior segment which affects the anterior segment parameters. And like I said, it acts at 4 successive levels. So now I'll talk of level 3, which is lens-induced. So we know that with age, the lens grows, it increases in size, resulting in a progressive decrease in the anterior chamber, the AC depth, leading to narrowing of the angles and elevated IOP. And also with increase in lens thickness, there's a greater predisposition towards pupillary block, which can again result in closure of the angles. And so one of the imaging-based parameters, the lens vault, like I explained, it quantifies the amount of lens that is located anterior to the anterior chamber angles. It is increased in eyes with angle closure. And this is what I'd shown previously. Now the CASIA-2 not only gives us measurement of the lens vault, but the other lens parameters as well. So in this study, we found that the lens vault is more strongly associated with angle closure compared to the other more traditional risk factors, such as lens thickness or lens position. And let me spend some time in this slide. So this is what we did was we compared the lens thickness in angle closure eyes and those with thinner lens and thicker lens based on the mean lens thickness of the angle closure eyes and compared them with normals. So as you see in eyes with thinner lens thickness, there's no significant difference between normals and angle closure group with the thinner lens. However, if you look at the lens vault, it was significantly greater in both groups, irrespective of the size of the lens. This suggests that the lens vault is a better marker for assessing the role of the lens because it gives an estimate of the amount. It's directly related to the angles, the amount of lens quantifies the amount of lens that is located in front of the angles. So of course, lens extraction and angle closure eliminates pupil block and widens the angle. And this is the EAGLE study. I think Ronnie will be speaking about it more on it. So basically, it's a multi-center trial which compared early lens extraction to standard care, which is LPI and topical medications. And what they found was at the end of 36 months, the eyes with lens extraction had a significantly better health status score and lower IOP as well as lower need of glaucoma medications. The study concluded that early lens extraction may be considered the initial treatment for PSCG and also PAC with elevated IOP. And this is a study which was done about more than 10 years ago from Clement Tham's group, where they compared Phaco versus Phaco trabeculectomy in medically controlled and medically uncontrolled PSCG. And what they found was that both Phaco as well as Phaco trabeculectomy result in significant decrease in IOP, but with the Phaco trab having marginally better IOP reducing efficacy. So this suggests that Phaco alone may perhaps be effective because it may be a feasible option for eyes with mild PSCG or those with medically controlled PSCG. And Phaco trab can probably be it's more useful for those in more advanced cases where you require lower IOP at all time points. Now, phacomorphic glaucoma, the secondary angle closure, secondary glaucoma. So this is what happens. Phacomorphic glaucoma is senile the intemescent lens becomes cataractous, increases in size, and mechanically obstructs the drainage angles, resulting in a sudden rise in IOP. So they present as an acute attack with typical signs and symptoms: redness, headache, corneal edema, conjunctival injection. And if you look at the fellow eye, unlike acute primary angle closure, the fellow eyes usually have normal AC depth. So in terms of imaging, you can see marked not only anterior chamber shallowing, but relatively very large lens, anterior-posterior direction. As you can see here, the lens thickness is about 6.34 millimeters, and it's quite dense as well compared to the fellow eye with a relatively normal size lens. And treatment for phacomorphic is urgent cataract extraction once inflammation IOP is reduced. Sometimes you may need pre-op IOP reduction using mannitol, acetazolamide, or LPI rhodoplasty may be done for the initial control of IOP. So in summary, the lens is a key modifiable risk factor for angle closure. Early lens extraction is effective is an effective intervention for mild PSEG, and urgent cataract extraction is essential for phacomorphic glaucoma to prevent optic nerve damage. Thank you very much.
Thank you, Monisha. Before you leave, I have a question. This is something that I put to my fellows very often, that if there is identical presentation of both acute primary angle closure and phacomorphic glaucoma, so according to what you said, the only difference is the largeness of the cataract or the lens.
I mean, yes.
So then
No.
should
Should?
they be then managed identically?
But if there is corresponding angle closure in the other eye, then yes, perhaps a PI. But if they do not have, then if the angles are open, then perhaps not. So if there is a component of angle closure or pupillary block in the fellow eye, with narrow angles, then yes. Perhaps not a cataract extraction if there's no cataract. If the vision is good, but definitely an LBI.
Right.
But if not, then no.